have met with some of you before, I think on the Disability Matters Committee, and we discussed similar issues. And unfortunately, I don't hear anything different today. And I'm just wondering in relation to the CDNTs, first of all, because I suppose that is an issue that is raised with me on a continual basis. Is there one person, who is leading the Progressing Disability Service? Is there one person in the HSE? Because none of you have a title where that's your specific role, and I'm just wondering, does it not warrant something like that? Or is there someone doing it? And just what measures are being taken to address the shortage of staff? As you rightly said, there's 28% on average shortage. I mean, you mentioned already that the career progression within disability services is an obstacle. And I know the HSE have implemented the interim recommendation of the career pathway review in primary care only. So I'm just wondering, why is that not being introduced into disability services? Or what other incentives are being offered to work in disability? Like, for example, I believe nurses perhaps are incentivised to work in ICU by an additional payment. Can something like that not be looked at? I'm just wondering if the inclusion of certain therapists on the critical skills list has yielded many staff into the system. And also, you talked about a shortage of graduates within the different disciplines. And I'm presuming you've informed the Department of Education and the Department of Higher Education. But I mean, in answer to a PQ recently, I was told by the Minister for Higher Education that there were 15 additional graduate places being made available in, I think it was physiotherapy. I mean, I'm hoping that I didn't get the full answer, that it was somehow that isn't the sum total of the additional places that are being created. Also, I suppose Section 39 organisations provide services on your behalf, and there's a discrepancy there with pay and other conditions as well. And until that's addressed, we're going to continue to lose staff from the Section 39s to the other organisations. And I know that mightn't be your responsibility, but at the same time, if you're contracting these organisations, I think there has to be a level playing field if they're going to work for the children themselves. And also in relation to services back into schools, I think there's a huge problem there, because the therapists are being taken back in from the CDNTs, which are already under-resourced. So, I mean, I don't know how that's going to work. Also, on assessment of need, there was a High Court ruling in March which found that the preliminary team assessment wasn't compliant with the Disability Act. I'm just wondering, has new guidance on assessment been circulated to CDNT since that? Because even just yesterday, a parent came to see me, and she's a 5-year-old son who's non-verbal. He received an assessment, but it was in February. It was dated as being compliant with the assessment of needs by the assessment need officer, but obviously that's changed since then. But having a quick read of that, it recommended that he would be given a full autism assessment. So I don't think that the original preliminary team assessments were addressing the backlog. What they were doing was putting people onto more lists to get a proper assessment, maybe for autism, or to access services, which they have not been able to access, because most people are coming to me and telling me there's a 2 to 4 year waiting list. So I'm just wondering, like, again, you know, if new guidance has been issued, what are we looking at in terms of time as clearing those lists? And I know, Professor McLaughlin, you said there that a diagnosis to access education isn't required, but unfortunately, because there are not enough special school settings, schools are insisting on the diagnosis because they want to prioritise those most in need. And I suppose having a diagnosis as well also provides vital info to the schools to help that child, because I know from being a teacher myself, and when I was the SEN coordinator in the school, getting information in from as it was the child development team at the time, was vital, and it was so good in just even small recommendations on how to assist an autistic child adapt to a new environment, and it made a huge difference. So I think if the CDNTs are working with children and providing info to schools, that's just is very important. I've also just another case there where a child who has been diagnosed with ASD and a mild learning difficulty, but also has a different, quite rare disease. The two are not connected, requires intense physio for the other disease, has been told to being able to access physio should go on to primary care, but will then lose the support of the CDNT for autism. I mean, can the two services not work together? I mean, I was told by Minister Mary Butler that the CDNTs and CAMS would start working together better. So, I mean, I'm sure the whole lot, primary care included, should be working together. So, I have another of other questions, but I'll leave them for the moment because I know I have a few there. But I'll leave you to address those first. Thank you.
So I might deal with some deputy, and Mac might comment on some as well. So in terms of the current structure around the leadership around the CDNTs, I'm the head of operations. So in that sense, the implementation of the policy is within my remit, and I have a small team of people who support me in that. We are currently looking at the structure around it, and that's something. Okay, I don't know what the outcome of that is going to be, but I suppose I am very aware of the point and that I think was implicit in your question in terms of the importance of having someone dedicated there, and that is something that I'm looking at. In terms of the impact of the critical skills list, I'll follow up on that with the HR colleagues, and I'll come back to you. I don't have an answer to be able to kind of specify what the benefit, but I will come back on that to you. In relation to Section 39 pay, that is an issue, not just in relation to our children's services, but across other service areas as well. And I know that it's something that has been raised with government. I think you're right that it's not something that's within our gift from the HSE to be able to resolve. But certainly it's something that we experience the impact of it in terms of engaging with organisations who are really challenged in terms of their staffing, and in different parts of the country that is having a significant impact. And I think it's certainly part of the suite of answers or solutions that need to be addressed. In terms of the options and the incentives around staffing, we are have a number of measures that we're finalising with HR in order to both recruit staff and retain staff. So we've invested, for example, and communicated out in the last number of weeks a very significant commitment to staff training. We are looking at sponsorship. We are looking at different types of contractual arrangements that might allow some flexibility for people. So, for example, and my HR colleagues now might be raising concerns about some of these, but for example, we want to explore the option of somebody coming to work for 4 years but spreading their salary over 5 years, so that they have an option of travel. It costs the HSE 4 years worth of salary for 4 years worth of work, but it gives somebody some options in terms of maybe travelling with some income, and also the job security of having a post to come back to. So we want to explore all, and we are exploring all of those kinds of opportunities and incentives, particularly mindful of a young cohort of people who might, who'd be interested in those kinds of things. So it isn't just a pipeline issue. Like, I think there are other things that we're also looking to do. In terms of the AON guidance, perhaps, Mac, you want to just comment on that?
Sure, yeah, thank you. And so again, in terms of leadership, I'm the clinical lead in disability, so I guess I'm the person responsible in terms of designing clinical programs. What you said about 39 organisations, couldn't agree more. And I think, in fact, in the Disability Matters Committee, I actually raised that was maybe something a Disability Matters Committee could look at, because that relates to public sector employment agreements. In terms of the assessment of needs, so that guidance has been developed and signed off by the highest level clinical committee within the HSE. We're obliged to go through the WRC sort of process where we consult with unions and make sure that they're okay with it. And I believe that hopefully that will be complete within the next few weeks. You mentioned about the previous standard operating procedure. We've previously presented evidence that 84% of people who went through the preliminary team assessment actually received some sort of intervention. Now, some of them needed further assessment as well. Essentially, that's gone now anyway, because Justice Phelan found it wasn't compliant with the Act. In terms of what you say about diagnosis, again, we're not in any way against the diagnosis. What we're saying is that that's not sufficient to identify what a person's needs are. To give you just an example, for instance, in the UK, every year there's 5,000 people who are classified as SWAN, where SWAN stands for Syndrome Without a Name. If one was to require everyone to have a diagnosis to have access to services, you know, those kids would never have access to services. But more importantly, as the recent literature review that I cited earlier on today emphasises, that sometimes an overemphasis on diagnosis can actually detract from the need to address people's needs and can sometimes misalign resources to diagnostic categories rather than the particular needs of kids. But that's not in any way undermining the importance of diagnosis, both in terms of authenticating sometimes people's experience or giving them a sense of identity around their difficulties.
Can I just come back on one point, Deputy? Just okay, the examples of integrated services not being experienced in the examples that you gave, that's not okay, and it's not what the design is intended to happen, and it should be the case that those services, you know, whether it's CDNT and CAMS or CDNT and primary care or whatever, or even combinations of all three, should be able to work together in support of a child, and it shouldn't be, children shouldn't be experiencing the risk of being discharged from one because you're accessing the other. It should be seamless.
That is what
I absolutely, you know, I hear that, but it's not what we're working towards or trying to be delivering, or you know, it should be that shouldn't be the case.
Chair, have a time just a couple of things. Just a parent mentioned to me about home support hours that was granted to her for her child, but she's been told in her particular CHO area that the worker must work only within the house, whereas her sister, who lives in the south of the country, has the same hours for similar reasons, and the home support worker can take the child out to the park or swimming or whatever. So it's just to get clarification that, you know, standardisation across services, and it would make more sense for the support worker to be able to take the child out. Also, just in relation to adult services, I had two parents of autistic adults, and they've associated mental health issues. They've both been placed in different residential settings, but they're not receiving any supports in there. They're being heavily medicated, and it's not addressing their needs at all. I have written to the Minister, I've written to the HSE, I'm not getting any responses. One young man has been hospitalised 3 times since January. And the last time, which is only recent weeks there, the pharmacist in the hospital, actually reviewing his medication, identified 2 medications which should not be combined, that had been prescribed by the psychiatrist attached to the residential setting. Now, it's not a HSE setting, but he has been paid for by the HSE to go there, quite a considerable amount of money. And his mother is extremely worried about him. He's very, very ill. And it could have been much worse if the pharmacist hadn't identified this. So just to highlight the fact that residential services should be there, or should have supports in them to support autistic people. And many of them, I believe, maybe would not have mental health issues if they got the proper supports, and if possible in the community, that rather than in residential.
Could I maybe just briefly comment? I don't know the specifics, obviously, of the case that you've identified, and I'm happy if you want to have a conversation with me outside of this to follow up on that with you. But in general, residential services are covered by regulation and are inspected by HICWA, and there are requirements that those in residential services have access to appropriate multidisciplinary supports. So in a way, there's I suppose a legal structure there to help drive something. There may be challenges in terms of availability, but I'd know that many service providers of residential services, would try and source appropriate supports depending on the profile of people in their service. But it should never be the case that somebody is on medications outside of proper supervision and review of those, and also the use of medication as an alternative to appropriate services isn't acceptable anywhere. So I'd be happy to follow up on that. In terms of the definitions of home support, and this overlaps a little bit with definitions of PA services as well, that is something that we're working on, and we're going to be convening a group to bring some clarity of definition and consistency in terms of accessing services, because we're very aware of the type of issue that you're raising, and that is part of our National Service Plan commitment for this year to progress that.
Thank you.